test instead of doing the lupus anticoagulant. And we don't have facilities to measure beta-2 glycoprotein levels. And there are other antibodies which can be measured, again very difficult in our situation. Sapporo criteria for classification of antiphospholipid antibody syndrome, which I just mentioned, have been revised again in 2006, but it was found that the revised criteria are excellent for research purposes, but not so for clinical decision making. So it's the judgment of the treating physician when he decides that his patients need treatment. But you should also remember that antiphospholipid antibodies, they can be present in other situations also, and medications, for example, procainamide, hydromyzine, phenytoin, these medications can cause antiphospholipid antibody in the serum. Infections, certainly hepatitis C, which is very common in our country, HIV infection, vasculitis, and neoplasms. So we have to make sure that in such situations, we know that antiphospholipid antibodies can be present without having the full-blown antiphospholipid antibody syndrome. So how do you manage them? And we'll come to all this different therapeutic options by selecting a patient, SLE patient. And thank you, I borrowed this slide from Sarah, she's here. Typical patient, very sick, in intensive care unit, butterfly rash, vasculitis, with literally death visible in her eyes. Hopefully, we'll rescue such patients before they end up in ICU. Typically starting with butterfly rash and SLE, but may not be present, only present in 30 to 40% of the people. And most of the time when I see patients with antiphospholipid antibody syndrome, they usually have an event which is arterial thrombosis, and we have to also remember, because you could have cardiac vegetations in such patients, they could be just throwing in of emboli. So we also have to rule out other hypercoagulable diseases, which protein C deficiency, protein S deficiency. With shortage of time, I cannot go into this, but you have to make sure that you have excluded other causes. And such patients can also come in with neurologic problems, which is severe headache, migraine, strokes, seizures, and MS-like situation. And now it has been clearly seen that they may actually give rise to a slowly onset of cognitive problems due to presence of antiphospholipid antibody syndrome, and can lead to dementia also. And what is catastrophic antiphospholipid antibody syndrome? And this is multi-system disorder or failure of multiple organs due to widespread thrombosis in various organ systems. And patients can have liver failure, they can have renal involvement, they can have seizures. So the most important thing in the management of such situation is that we must identify the treatable factors. Usually infection is precipitated, and we must immediately admit them, anticoagulate them with heparin, and we have to treat them differently. We have to give them high-dose glucocorticoids, and for microangiopathy, plasma exchange with or without IV immunoglobulin would be one of the other treatment options. So what do you do with patients who are pregnant and have APS? So if they are pregnant and they have APS, and they have had prior fetal death, or they have recurrent pregnancy loss before. So here's a patient who comes in and tells you that I'm pregnant again, but I had an abortion last year, but here I'm pregnant again, and I have antiphospholipid antibodies. So what do you do? So for such a patient, you would use heparin, and there are different varieties of heparin which can be used. In the traditional heparin, because that is less expensive, and you can give a total of 15,000 units in 3 divided doses, like 5,000 units, and it is very cheap. Or otherwise, you could use the other types of heparin which you do not need monitoring. And some people would also put in low dose of aspirin here. But if the patient is not pregnant, like a man who cannot be pregnant, but Optimal management would be uncertain in such a situation when women is not pregnant. But what would you do? Probably you would just add a low dose of aspirin in such a situation. Now, if you have a patient who has had prior thrombosis or stroke, and the patient is pregnant, and you know that that person has had this previous event, you will heparinize and achieve full anticoagulation, because heparin does not cross the placenta, and throughout pregnancy such a patient will have to be on heparin and monitored, and there's certain complications. One of them is thrombocytopenia, and you're stuck with a patient who needs heparin, and heparin is causing thrombocytopenia. So we can use other aspirins for that purpose, and there is 3 different types of heparins which are available, which you can use in patients with thrombocytopenia. Now, if the patient is non-pregnant, what would you do? You will administer warfarin and daily in doses to maintain an INR around 3. Now, if you have a patient without prior pregnancy loss or thrombosis and she's pregnant,